My name is Nanama Anabempong and this is GH Today and you are watching Health Check. Today we are talking about polycystic ovaries. Now, polycystic ovaries is something that 10% of Ghanaian women suffer from. So we're going to get a little bit more information from Dr. Paul Enin at the Airport Women's Hospital. He's a consultant OBGYN and I'm really interested in what he has to say today. We'll be right back. Okay, Dr. Paul Enin, you are welcome to Health Check today. Thank you so much for your time. So as I said earlier, we're speaking about polycystic ovaries. Can you give us an overview of what exactly polycystic ovaries is, please?
Well, polycystic ovaries, as the name implies, presence of several follicles that are seen in women's ovaries. Now, seeing the cysts themselves is not a problem, but there are several issues that precede the condition. When a person has polycystic ovaries, there are a series of symptoms and signs that tell us that this patient has polycystic syndrome. The polycystic ovary itself is not a disease, but it is the syndrome that is associated with it. That is, there are several groups of women who present in diverse ways with the same condition called polycystic ovary. That is why it is usually referred to as polycystic ovary syndrome. And for short, people call it PCOS, P-C-O-S. That is the average terminology that the average person might come to the doctor and say, oh, somebody has talked to me about PCOS. And they mean polycystic ovary syndrome.
Okay. So you mentioned that there are some symptoms that precedes somebody being diagnosed with that syndrome. Can you give us a bit more information, please?
Yes. The polycystic ovaries is a condition that is due to abnormalities of the hormonal environment in the person or in certain women. It presents in very diverse ways. Some people have infertility. Some people have difficulty in ovulation, which will also lead to infertility. Some people will have skin symptoms, commonly due to maleness, male abnormalities of male hormones in a woman's system.
Okay.
So that if you look at them in their faces, you may see hair. There are certain women who have a hairline that shows as if they have a mustache. If you watch them carefully, they tend to have sideburns.
Okay.
They tend to have some little beard. And if you were to look in their chest, you might find a couple of hairs on the nipples, and if you were to look in the abdomen, you will also see hair growth towards the belly button, which is not a typical, that's a typical feature of men. Women have their pubic hair line lining in a triangle, and the texture of even their hair tends to be hard, not the velvety kind of hair that the average person may have in the pubic area. But theirs tend to be hard.
Okay. So is it fair to say, or maybe you can correct me so that everybody can have an idea, any woman with one of the following: facial hair, like extra hair growth, you know, the symptoms that you mentioned, if you have any of those, does that mean you have polycystic ovaries?
Well, those are features of what we call hirsutism, as maleness. There are certain conditions in the ovary that will make you have those features without necessarily having polycystic ovary. If you have certain tumors in the what we call adrenal gland that produces male hormone, you would do that. If you have certain tumors in the ovaries that also produce male hormone, you may have that. But remember, polycystic ovaries, it is not a tumor as such. It's not a cancer. It is normal pattern for these people. They tend also, if I forgot to mention that, tends to be associated with diabetes, difficulty in getting pregnant. It's the main thing that would bring them to us. Happens in the younger age group, happens to about 10% of women who are trying to get pregnant. So those are the conditions that is what has made PCOS or polycystic ovary a topical issue that people would want to know about. It is the infertility aspect, the anovulation that you cannot tell. They have irregular cycles. They may miss cycles. In other words, their periods may be prolonged. They may be delayed. Instead of having their period every 28 days, theirs may go 30 days, some may go miss their period for 2 weeks, and then they will come. Then when it comes down, it may bleed much longer, for a much longer time than the usual 4 to 5 days. They may bleed for 8 days. Or sometimes they may miss even the period. The period comes every 2 months or every 3 months. Those are the common symptoms that they might come to the doctor with.
So is it every lady or every woman that has polycystic ovaries, will they always encounter difficulties in childbirth? Not childbirth, sorry. Will they always encounter difficulties in
getting pregnant?
Yes.
Not always. That is what makes it difficult for us. There are people who may have all the symptoms, all the hairs, and yet pregnancy is easy. And there are some who may just have the delayed menses or skipping cycles and have a difficulty in getting pregnant. So it's not all of them. There are people who have all those features and they have 5 or 3 kids easily. So it makes it difficult for us to know who we should take seriously and who we don't take seriously.
So it can happen to anybody at any time?
Happen to anybody. The question is it familial? Is it hereditary? The literature is not clear on that. So it is not hereditary.
And what are the treatment options? Is it that you would remove the cysts or they would remain? How does that work?
Well, that's a good question. They tend to have, sometimes some people have 30, 40 follicles in the ovaries.
How big would it be?
They usually are small.
Okay.
They usually are small. Between 1 to 9 millimeters and under. So they have small dots all over the ovaries. And in fact, when we cut a cross section on a scan, you see round circles at the edges of the ovaries, and we call it a pearl sign, like a lady's pearls around your neck, dots all the way around. That is how it is seen on the ultrasound, that somebody has polycystic ovaries. But the question was, how is it treated? Yes, the main thing that will bring the person to us would be the reason why we would treat. For those who come in because of the hairs and nothing else, that is where our attention will be. For those who come in, majority of people will come because they want to get pregnant.
Sure.
They've been trying. So the treatment I must say that, first say that we don't have treatment for it.
Oh, okay.
But there are, because the symptoms are so many and varied, and different people present differently. So one treatment doesn't fit everybody.
Okay.
So it becomes difficult, and the more we do that, then it tells you that we physicians who deal with it, I don't want to say that we don't know what we're talking about, but the information is not written in gold. It's still evolving. We're learning new things about the disease every day.
Sure.
But For those who want to get pregnant, the treatment is ovulation induction. That is, we induce them with tablets that we have that they have to take every month. They come, we give them tablets to start their cycles off on the first, second to the 6th day, or from the 5th day to the 9th day. Take tablets for 5 days for them to ovulate. Because sometimes they produce a lot of eggs, but they may not be mature. Hence, if we're going through, the commonest is giving them the tablets to induce ovulation, and we take it from there. So a lot of, I would say, about 50% will get pregnant from the medication that we give them. But because it's a complex disease, when I say that simply, that doesn't answer it all. For some people, we have to give them medication that are anti-diabetic, because the condition has something to do with diabetes also. It's common in patients who comes from a family history of diabetes. And eventually patients who tend to have that condition, if you observe them later in life, they have diabetes. So one of the treatment is to give them anti-diabetic medication. The most popular is metformin. That people come and pharmacists will say, why, you're not a diabetic, why are they giving you a diabetes medicine? But we take that medication along with the our ovulation induction. And if, depending on the age, we go through several processes. The end point will be very strong stimulation with what we call gonadotropins, and produce so many eggs that we may have to resort to in vitro fertilization. And when we get into in vitro fertilization, these people are so sensitive to the medications that we use that they tend easily to have twins, triplets, multiple pregnancies. And that's a risk when we start inducing them. They tend to produce multifetal pregnancies.
That's great. I know a lot more about polycystic ovaries now, and moving a little bit along to the tubes.
Well, I'm not quite done with
Okay.
polycystic. As I said, because presentation is variable, there are so many other things that can happen. Because the ovaries have so many follicles, sometimes the treatment is what we call ovarian drilling. That we drill holes in the ovaries to break some of the follicles that are...
Are they hard?
Follicle means it contains fluid, cyst. Fluid. So we puncture several of the follicles to drain the fluid out, and somehow they tend to function better after that. So that is ovarian drilling. So that if somebody goes to a doctor and they said, we're going to do ovarian drilling, then that is what they mean. And to do the ovarian drilling, the ovary is inside. So how do we get to it? We will do a laparoscopy where we make an incision below the belly button, take a look at the ovaries, and then put a long needle to it and puncture this various cysts to let the fluid drain. And also, in the past, they also used to be, because the ovaries tend to be enlarged, big. So we used to do what we call wedge resection, where we cut a portion of the ovary off to remove some of the cysts. And somehow, after we've removed them, they function better. And this is seen in people who tend to be obese. And again, when you ask me about presentation or symptoms of some of the polycystic ovary patients, since patients with polycystic ovary syndrome tend to be obese. So when we do the wedge resection, we take some of the follicles out, they tend to respond better.
Okay.
And again, we advise weight loss, again, as part of the treatment.
Okay.
So when they lose the weight, the male hormone environment, which creates the hairs, we call it androgenicity, also goes down.
Okay.
So if they can control the weight and bring the weight down, really, weight loss, once you can achieve weight loss, for those who even have irregular menstrual cycles, who may skip their periods for a month or 2 or 3 before it comes, if they lose the weight, eventually you will see that the cycles start coming normal, where they have the cycles every month. And once we start getting cycles every month, they tend to respond to treatment. They get pregnant easily thereafter.
So it really depends on the severity and how many cysts that are found.
And the symptoms, and we call it various phenotypes. That is, the presentation in people may be different, and hence the treatment then is tailored towards a particular person. Because, I mean, you are average size woman, but you can have polycystic ovaries. Yet you can have also an obese person walking in with polycystic ovary syndrome. So whereas I will not advise you to lose weight, for them, I will advise them to lose the weight and put them on a weight loss program. And then you will find that their symptoms will abate and they start having regular symptoms.
Dr. Eni, thank you so very much. You've really helped me to understand a lot more about polycystic ovaries, and I'm sure others will also be grateful for the information that you have given us today. Thank you.
You're welcome.
So that was me, Nanama Anna Bempong, on Health Check today, and we were talking about polycystic ovaries with Dr. Paul Enin, who is a consultant OBGYN at Airport Women's Hospital. See you again next time. Thank you.